My guest tonight is Dr. Jay Varma. If he looks familiar, he should look familiar because he was on television every day during the beginning of the pandemic. And that's because from April 2020 through May 2021, he was the principal scientific spokesperson and lead for New York City's COVID-19 response. In September of 2021, he joined Weill Cornell Medicine as professor of population health sciences, and he directs the Cornell Center for Pandemic Prevention and Response. Dr. Varma is an expert on the prevention and control of diseases, having led epidemic responses, developed global and national politics, and led large-scale programs that have saved hundreds of thousands of lives in China, Southeast Asia, Africa, and the United States. After graduating magna cum laude with the highest honors from Harvard, Dr. Varma completed medical school, internal medicine residency, and chief residency at the University of California, San Diego School of Medicine. He's won lots of awards, authored 143 manuscripts, 12 essays, and 1 book. So welcome to the show. Appreciate you being here. And so I was just looking at the COVID, statistics in New York, and they said that since March 20, the city has been tracking COVID-19 cases, hospitalizations, and fatalities in New York City. So there have been 2,332,124 cases, 40,132 deaths, and it says that 86.7% share of New York City residents are vaccinated. Although I don't know if that means that, I doubt that means they've been boosted, because I know the boosting rate's pretty low. So why don't you talk a little bit about what you did when you worked for the city?
Yeah, thank you, David, much for having me. And I think, I guess before I get into that, I think every time, I hear the number of deaths in the city since the beginning of this pandemic, I think you could do nothing but sort of, pause and feel a tremendous amount of sadness for the loss that not just of the people that died themselves, but of course all of us who have lived since that time. And as those who lived, for example, through the HIV epidemic, there's the loss of loved ones, but then there's also the survivor feeling as well too. And I think and the fact that deaths continue to accumulate, there's something like 20 to 30 deaths on average per day here in New York, which is again something I think many of us didn't think was likely to continue to happen this far into it. So getting back to your question, so my sort of story begins that I spent 6 years in New York from 2011 to 2017, serving as the deputy commissioner at the health department, where I oversaw all the infectious disease programs for the city. And then in 2017, moved to Ethiopia, where I was based at the African Union. I spent a lot of my time working in public health overseas, and thankfully I've had a very flexible and resilient wife and children who've been willing to wander around the earth with me, and was working to establish a new public health agency for the African continent. Actually had written the African continent, continent-wide strategy, and was leading many of the different response components for the African Union. And then was contacted actually originally by Corey Johnson, who was then the head of the city council in early March, asking for some advice. He said he was struggling because, the mayor and the governor, he didn't feel like they were taking aggressive enough action and there was fighting. And so we started a correspondence really just because I felt an attachment to New York. I was planning on coming back with my family to New York City after finishing my stint in Africa. And so was providing him with extensive advice. And then eventually he connected me first with Emma Wolf, who was the mayor's chief of staff and chief advisor. And Emma and the mayor actually requested that I come back to New York City to help provide strategy and guidance. So I landed back in New York in April of 2020. And my job was to, basically come up with a long-term strategy for the city. One of the things that was actually surprised me a little bit when I arrived here was that there was no long-term strategy. Nobody had sat down to think, well, how do we get us to the point when vaccines are widely available, and what are we going to do after that point? But really, even just at that time, I would sort of set my eyes on summer 2021. By that time, I'm sure vaccines will become available and we'll probably get to a better place. underestimated the speed with which the virus would mutate, obviously, and we can talk about that later. So that had been my idea, was to come up with a big strategy. And so that's what I did. I spent the first couple of days with the mayor working on a strategy that basically led to the establishment of our widespread testing system, our contact tracing, our we call isolation and quarantine hotels, and then worked on all of the aspects of policy related to reopening, the most challenging of which was definitely the schools, but also on a number of areas related to businesses and other things. So basically spent on a daily basis from April of 2020 until May 2021, working on public speaking, on policy development and data analysis. And then from May 2021 until December 2021, I worked part-time just as a consultant for the city.
Okay. So what were your biggest challenges, would you say, and what did you think the city did very well?
Yeah, so lots of big challenges. I mean, I would say, the first big one that I had to try to tackle was the limited testing capacity. One of the biggest challenges that we faced in New York at the peak of that epidemic, and actually before then, if you think back on it, and this is a real, failure across the United States. It's not unique to New York, but we had ample warning. We knew by the beginning of January that there was a respiratory virus. We didn't know how contagious it was. We didn't know it in any symptomatic phase. We didn't know a lot about it, but we knew there was a dangerous virus. I myself had been a U.S. government advisor in China for 3 years, from 2008 to 2011, working in Hubei province where Wuhan is. So there was plenty of awareness across the U.S. government about the risk that this posed. And the sad part is that, this virus circulated basically undetected from January until early March because of an absence of testing capacity, which is really just unconscionable and something that we hope never repeats itself. So my first biggest challenge was, when I arrived here in early April, was how do we scale up testing capacity? Because by that time, even though testing was available, there were so many people sick that the city hadn't built the system to be able to diagnose large numbers of people. I think I estimated somewhere between 1 in 10 infections at the most were being diagnosed at that point. So the first challenge was, how do you build testing capacity? And so that was a major challenge. And I'll touch on a couple of them, and then we can dive into deeper detail about these. The second challenge was building a contact tracing system. The city health department had very similar to all the other state and local health departments, who basically said, look, there's no way we can do contact tracing effectively when there's vast number, thousands of new infections occurring every single day. I came from a different perspective. I came from the experience of working overseas, where you're not constrained by the concept of scarcity. I mean, that's a lesson that's come out of the HIV and the TB experience. You do what you can with the resources you have, but you consistently try to ask for more, like, what is it we need? And you try to get that. So I was able to kind of, convince the mayor and his deputies very early on that we needed to spend huge sums of money. We estimated at least $1 billion. I think the final total ended up being between $2 and $3 billion to build a comprehensive contact tracing and isolation and quarantine system. I think the next biggest challenge was really these issues around schools, which is one of the most, what we call wicked problems in social sciences, which is like problems where you're really dealing with, trying to come up with the least bad solution to a problem. And then I would say finally, it was managing, let me say 4 or 5. The next was really kind of managing the complex issues about opening and reopening across so many different sectors of society. And then finally, it was the vaccine scale up and all of the issues related to, how you prioritize who gets vaccinations, how you ensure equitable distribution, and then also what you do about mandates. Are they necessary? How are they, how do you balance incentives, carrots and sticks? So, that probably is a quick, rapid run through of all the major areas that I dealt with, and happy to discuss each of those in more detail with you.
So I want to discuss mandates because, as you know, the city workers had to get vaccinated, policemen had to get vaccinated, firemen had to get vaccinated. We had the famous basketball player who didn't get vaccinated and could play anywhere else but not in New York City. I think Kyle Irving. Now he can. And just today they announced that the mask mandate on planes, the federal judge ruled that the CDC exceeded its authority and it's ending. Even though it was supposed to only go until 2 weeks through.
I think you extended it for 2 weeks. Yeah, to be extended potentially longer, but at a minimum for 2 weeks. Yeah.
So now will the mask mandate end April today, or will end April or will end?
Yeah, I haven't seen a statement from the White House yet on this. I
No.
mean, obviously, I'm sure they're trying to do an emergency appeal and to stay this. Like, as those of you who follow sort of politics and law, like I do as a junkie, there's been this movement for federal district courts to issue nationwide injunctions. So even though the lawsuit was only brought, in one region, they're
Right.
basically having to cover the entire, nation. And so I don't know what the status of that is. But let me step back for a moment and talk, and then you let me know which sort of direction you want to go in, because I do think masks and vaccines are different issues. But I step back and basically say that what mandates are fundamentally is the exercise of law to kind of structure, enable, and enforce public health. And I think a lot of people, particularly troubles me, a lot of people in academia even don't actually recognize the extent to which law is such a critical part of public health. And that's actually something that I spent a lot of time in, both when I was deputy commissioner, when I was working in Africa, and then also in particular when I was, working in City Hall is, no matter what your best, instincts are in public health based on the scientific data and your assessment of what's feasible and acceptable, everything you do has to be legal, right? So you learn a lot about the importance of administrative law and how it can work and how it can't work. Now, we know from the history of vaccines that vaccine mandates are first of all have a long tradition in the United States. The first vaccine mandates documented in U.S. history are those imposed by, George Washington on his soldiers. So they're as American as George Washington is. Second of all, there have been a number of court rulings over the years. The most famous one, occurring in I think 1904, the Jacobson ruling, basically saying that mandating, protecting public health is a fundamental legal authority that states have under the 10th Amendment. They're called the Police Powers Clause. So they have a long tradition, they have long legal standing and basis, and most important, they are tremendously effective at increasing vaccination levels. I mean, despite all the complaints that people hear about the US public health system, where we have excelled globally is in childhood vaccination rates, for high priority diseases. And that's because we have strict mandates. The number one predictor of high vaccination rates in a US county or state is a school entry mandate that with no or limited exemptions available to it. So vaccine mandates have a long tradition. They are legally grounded and they are highly effective. So that's why I've always been a very strong advocate of vaccine mandates. Mask mandates are new. And I think that is where there is getting to be this challenge where you're getting a lot of this, I think you get this fervent protestations for it, and represents a much more difficult challenge, as we're seeing from the Supreme Court ruling today as well.
Okay. Thank you I want to thank my for people listening in. If you have questions, please put it in the Q&A box. The chat box is really just for me and my co-chair, Joe Bonner, who runs the tapings and all this stuff. But Doug Levy, who was actually the first person I interviewed several years ago when I started this series, he said that the White House issued a statement about the TSA. The agencies are reviewing the decision, assessing its potential next steps. In the meantime, today's court decision means CDC's public transportation masking order is not in effect at this time. Therefore, TSA will not enforce the security directives and emergency amendment requiring mask use on public transportation and transportation hubs at this time. However, the CDC recommends that people continue to wear masks in indoor public transportation settings. So we're in a kind of strange time that they're ending all these mask mandates everywhere, and the COVID rates are rising. Philadelphia brought back, it's the only New York city in America that brought back the indoor mask mandate. I read that there's some areas of Manhattan that the rates are as high as 15% of positivity rates.
Yeah, so I mean, there's lots of issues to discuss. So, the first is, for me, the biggest hazard here is not the acute one, which I know we should talk about. Obviously, the acute hazard is, the risk of people getting COVID and dying right now. What really worries me are the long-term consequences of this. Essentially, what you have seen throughout the past 2 years is at the federal level, basically entirely right-leaning judges, many of whom were appointed under President Trump, gutting the ability of the federal government to do things that all of us who look at data and science related to public health would argue have a strong scientific rationale. And then everybody who works in public health law would argue that the federal government has the authority to do. This goes back to them, to the Supreme Court voiding the ability of certain states to impose regulations that required people attending indoor religious services to wear masks. It covers gutting the federal government's ability under OSHA, occupational health law, to regulate COVID transmission in occupational settings. And now it extends to the, preventing the ability of the federal government to regulate interstate commerce, which is the fundamental basis by which the whole of Congress was established and federal government was established, was to have the ability, authority, and CDC's authority to regulate interstate or ports of entry. So the long-term consequences are actually what really upsets me the most. Now, for people who are listening and yourselves, obviously your biggest issue, and appropriately so, is the acute threat to your health right now. And the reality is that if you're going to be traveling and spending a lot of time indoors with people, that is the hour or 2 or 3 hours you're waiting in an airport, the 30 to 40 minutes it takes to board a plane, the time you spend on the runway, the time you spend landing, those are high-risk places. You are mixing with a lot of people without that much air circulation effectively. The exception there, and you may have noticed from what I said, is the time that you're actually spent in the air with all of the air handling systems on the plane is actually relatively safe. I mean, the air handling systems on a plane are actually have much better ventilation than a lot of other facilities. I would still recommend people to wear high-quality masks during that time, but if you have to take a mask break, interestingly enough, being at high altitude in the plane is probably a safer place to do that than taking a mask break, while you're in the waiting room waiting to board or deplane.
So, we're in New York City, the Science Rise New York. So, up till recently, I guess last month, to eat indoors, you had to show your vaccine card. To go to a basketball game or whatever, you had to wear, had to show your vaccine. To go to the US Open, at first they said anyone can go, then Mark Levine said, wait a second, this is the epicenter. So that you had to show at least proof of vaccination to get in. And to do indoor dining. Now theater, they're going to end the vaccine requirement April 30th, but they're going to keep the mask requirement, they said, through May. So that's one of the few places that has had both. And I guess that's important because shows get, actors get sick, that's it. I saw a show and Plaza Suite, and the husband and wife team of Sarah Jessica Parker and Matthew Broderick both got sick in the show. People aren't going to go to the show without that. So shows. Yeah. So that's a big risk. I guess my question is, what is the hurry to end these requirements? I mean, you would think you would end the requirement when the COVID rates are like down to 0, but instead we're ending requirements when COVID rates are rising. I mean, CBS Evening News today, they said COVID rates are up 50%. It's something like that.
This is, we're on this crazy sequence of events where, all of a sudden, transmission goes down at some point, and then everybody wants to celebrate by removing all of the protection measures that have kept you where you are, and rates then go back up again. So, there's a fundamental lack of understanding across the spectrum from our elected officials on down that we need to be treating this virus the same way that we would treat a threat to physical health, like terrorism, or a violent threat, or like extreme weather events. Like when it's raining, one day and then it's sunny the next day, I don't take my umbrella and throw it in the trash and my raincoat and put it away. I put it away knowing that I'm going to have to put it back on again, that it's going to rain yet again. And one of the first things I did, you asked me at the beginning of this, like, what did you do when you got to New York City? Literally the first thing I did was I wrote this document for the mayor that basically showed the waves of an epidemic, and that we're going to ride up and we're going to put restrictions in place. We're going to come down. We can probably pull back some restrictions. Then we're going to ride up. Then we're going to have to pull things back, put things on, take it back up. And said that over time, those waves will get lower over time, and you'll get to a point where you can go relatively back to normal. What's changed is the fact that none of us, and by say none of us, I mean all of us who work in the infectious disease world, did not anticipate that this virus would mutate into such highly transmissible forms at the speed with which it does. All viruses mutate, that's their behavior. That's what they do. But the speed with which it has developed highly transmissible forms to be 10, 15 times more transmissible than its original form from over 2 years ago is something we just never seen or witnessed before. It's basically, COVID seems to do within months or a year what the flu virus takes 5 years to do. So that's been the challenge. And so as a result of that, what you see is that everybody, and by everybody, I'm referring to broadly to elected leadership and the loudest voices, are basically trying to say, well, we're done with the virus, even though the virus isn't done with us, right? And everybody wants to use, the beginning they were misusing this term herd immunity. Now everybody's misusing this term endemic. And fundamentally, for those of us who work in infectious diseases, all endemic really means, there's an epidemiologic definition that has to do with the reproductive number, and that, it generally stays below 1. And so therefore rates are not consistently rising. But that doesn't really apply to everything. Honestly, what endemic means is that people with power and privilege no longer see themselves a threat. Therefore, they're willing to accept a certain level of disease in the population. And that's kind of what we're at right now, is that even though rates of infection are rising, there's a tremendous reluctance to acknowledge that and do anything about it. Now, I'll say one more thing and then I'll stop for a moment, so you can ask more questions. But, there is some reassurance right now that you're seeing the benefits of widespread vaccination, and partially, a benefit, if you can call it that. It's a benefit that comes with harm of widespread infection, inducing immunity. So the combination of both vaccinations and infection-acquired immunity does seem to be, at least in New York City, keeping our hospitalization rates much lower than I would have necessarily thought that might happen. In fact, I was basically agnostic. I wasn't sure what direction things would go, honestly. So that is a good sign. But to me, that is very similar to saying that, again, using a weather analogy, that you had a bad tropical storm right now, and it wasn't a Category 5 hurricane. So good. Be relieved. That's good that that's not happening. It doesn't mean people didn't get harmed. Doesn't mean there was damage, but it's good that it wasn't disastrous. But it doesn't mean we can't also have another bad one in the future. And the behavior of this virus so far has been, it continues to do more dangerous things. It doesn't come back in more safer forms.
Well, I thought of the umbrella analogy and just thinking, every time we go through TSA, we have to, you have to take your shoes off. You have to take your computer out. And someone could say, there hasn't been really a terrorist attack since 9/11. Let's stop it. But no one's stopped. No one is talking. No one's calling for that.
I've used this example with people before. In fact, I went back and looked. Airline security. To the extent we know, essentially metal detectors and screening luggage. That started in the early 1970s after a series of hijackings on planes. Yes. Right. That has not ended. And people keep asking me, I get these trolls on Twitter, and then you have people who are sincere, who genuinely say, well, you just want this to go on forever. You can't tell us when it's going to end. And you're right. I actually can't tell you when it's the end, because I can tell you what I'm looking for. I'm looking for the virus to stop mutating into forms that consistently present a threat to the human population, because they are either more infectious or they evade existing immunity. That day will happen. The evolution predicts the fact that this virus can only change the sequences it has right now. It's not, as far as we know, it's not going to adopt, incorporate new sequences from other places and become a whole new virus. So there will be a point in which it will reach some form of evolutionary stability where our immunity as a population, I'm just referring to, let's say, New York, for example, based on infections and vaccinations, will be enough that people will continue to get some type of respiratory illnesses, but severity of the disease will go down. That is the end point. The problem is I can't predict when that's occur any more than I can predict when the US will stop being at risk of people wanting to kill Americans or blow up American airplanes. I have no idea when that is. So you keep security measures in place because of that. I have no idea when we will develop effective vaccines against salmonella and E. coli and norovirus and all the other things that cause gastrointestinal illness. So until that day, I'm going to wash my hands pretty religiously every time after I go to the bathroom and before I eat. So I don't stop doing that suddenly. So it's very, very perplexing, because I understand it because I work in this area, and so I can have that perspective. But I really wish there was a much broader understanding of the fact that this is not something that people wished upon this earth. It is just a consequence of a whole number of other factors that are at play that are releasing dangerous emerging infections into the world, and we have to live in a more dangerous world than we would like to. But there is optimism. There are endpoints to these things. I just can't tell you exactly when that is.
Okay, so I'm going to get into some questions that were submitted. And there's only one question in the Q&A box. So if you have questions, please put them in now. What is the likelihood that booster doses and Paxlovid will be
Yeah.
available to all regardless of age or medical condition? Is it a question of supply/cost? With the unpredictability of long COVID, and since we're basically on our own now to manage the risk of contracting COVID, it'd be great if everyone could have access to the tools to help prevent a negative outcome. Thank you.
Yeah, excellent questions. And I want to highlight something in that question that's really important, which I probably have the mistake of not highlighting enough too, which is that, really what you're talking, because oftentimes I get criticized because, by, again, people who want to sort of move on and say, we just got to move on, by people saying, well, look, vaccines only provide now 30 or 40% protection against infection from Omicron. But that's so much better than 0% protection when you're dealing with a virus that has not shown us in any way that it is benign. It causes this whole constellation of dysfunction in people's blood vessels, in their organs. And while kids appear to recover quite well in general from this disease, except for, some people get these rare inflammatory conditions and longer symptoms, it's quite uncommon. We don't know what the consequences are of repeated infection. And we need to be thinking as a society about how much we want to continue to, acquire these things. So let's get to the two questions at hand. So let's first talk about vaccinations. So, and this is another challenge that's come up is unfortunately this terminology got termed that these are boosters. And actually what we see right now from all the data that we can see, at least for adults, let's talk about adults first. This is basically a 3-dose vaccine. And that's true for a lot of vaccines that we have that require multiple doses, whether it's polio. Originally we thought the HPV vaccine was a 3-dose vaccine. Now we're learning you don't need that. Hepatitis B virus is a multi-dose vaccine, measles, mumps, rubella. There's lots of vaccines that require multiple doses. So it's likely that people will require at least 3 doses to maintain immunity, but it may be that they require more in the future. Now, at least in New York City, I'm not aware that anybody is blocked from getting an additional dose of vaccine. The official authorization for boosters is, and I have to double check this back because I haven't kept up with the literature, is basically anybody who's an adult, or actually 16 and above, I think, is eligible for a 3rd dose of vaccine, because my son, who's 17, and my youngest of my children, has gotten it. So basically anybody up there. So for children younger than that, it's not yet available. There's some debate about its necessity in that group. And given that there is a very, very small risk of what's called myocarditis from additional doses of vaccine, not the first dose, but usually from the second or additional doses, there's some debate about whether it's necessary. So often what I do is I'm a strong advocate of a 3-dose series in anybody who's basically 18 and above. But I'm less sort of strident about that for those younger than 18. So in terms of widespread availability, that's just, but the biggest vaccine gap we have right now is children under 5, right? And that I don't have access to the information, but there's this intense negotiation going on between Moderna and Pfizer with the FDA about what data they need to see, because I think what Pfizer and Moderna want to do is show what we call proxy or surrogate endpoints, which is like, look, it produces a certain level of antibodies, therefore it will protect you. But I think what FDA is pushing for is actual data on number of infections and severe outcomes. So that's where the challenge is. Paxlovid, the drug that the person asked about, appears to be a real miracle drug in terms of its effectiveness in helping people recover very quickly from this infection and preventing severe illness and death, particularly those who are vaccinated, and then also particularly people who are unvaccinated, but also I think additionally people who are, even though it's officially not for people who are vaccinated, people are getting it, because they're at higher risk, and it appears to be quite remarkable. So my hope is that it will eventually become available both for a wider population, that is, you don't have to have certain risk factors for severe illness, number one. And then number two, that it will also become available for what we call post-exposure prophylaxis. That means you were exposed, like you had a contact, and you can take it to prevent getting infected. So I think that's we're likely to see data on it. So now let me explain two important caveats to this. The first is that this is not an easy drug to manufacture. It turns out to be quite complicated to make because of all the steps that are required in it. So that has been the major bottleneck in supply. So I think the person was fundamentally asking, is it a problem with supply? With vaccines, the issue of third doses or fourth doses is not about supply. It's more about benefit and data on that. With Paxlovid, the single biggest challenge right now is drug supply. So that's number one important caveat. And I think that supply will be sort of really ramped up over the next 6 to 12 months, but that doesn't really, answer the question of today. But if you're in New York City watching right now, the city has a very large supply. So if you do get sick, it's worth calling the city's hotline to get that. The second caveat I will raise, and this is not to inspire, it's not to make people worried or to cause fear. It's just to be aware of what might happen in the future. There is a lot of concern about many of us who work in infectious diseases that anytime we've had a single drug to try to treat a virus, we have found that the virus finds ways to outsmart that drug relatively quickly, and that you often need combination therapy, multiple drugs hitting the virus at the same time so it doesn't mutate. And many of us, myself included, are a little nervous about the long-term public health implications of making Paxlovid available to everybody because of that. I think it's difficult to make a policy argument that you should restrict use right now, given that we don't have evidence of this harm. But it is something for people to be aware of. There is a possibility that widespread use of Paxlovid could lead to the virus developing mutations that therefore the drug becomes unusable. So this is a challenge that we face with a lot of things. It was a challenge, for example, with HIV when AZT or Zidovudine first became available, for example.
Yes, I know that, one of my family members came ill and she's under 50 and they said, no, they'll meet the criteria, no risk factors. Here's a question. How would you rate the CDC's communication efforts during the pandemic?
Oh boy, yeah, this has been less than ideal. And let's go back a little bit and deal with a couple of things. So, the original problem that CDC faced, and I do think to this day it's struggling with this. I know it's hard for people to believe because it's been over a year and a few months since the Biden administration took over, but I think it's still struggling intensely from a lot of the problems that happened in the beginning of the pandemic. In the beginning of the pandemic, CDC was not able to play the role it has historically done in pandemics. And so that is, number one, have routine, regular communication with the media and the public through press conferences. And that discourse with the media is incredibly important. I can tell you from having done hundreds of media interviews over my career, it actually refines your thinking and your policy so much better because, when you outsource ideas to smart people who are asking and looking and poking holes in them, you get better at seeing this. So just the CDC's, being strangled effectively by the Trump administration at the end of February, and basically being told you can no longer talk publicly about this disease, I think really hampered CDC's ability to message publicly because it couldn't actually explain its thinking or what we would call show your work. That was first problem. And then, so the second problem then became the intense political interference that occurred, everything from, restricting who should get tested to the school's guidance. And so that undercut CDC's scientific basis and basically caused a widespread morale problems and job losses at CDC. So that's during the Trump administration. So then when the Biden administration comes in, they kind of almost swung in the other direction and said, okay, well, CDC, now you should go forward and put out public policy. And one of the problems that's happened, and I think this comes with some of the dilemmas about, and this is where I've been, unfortunately disappointed with the Biden administration, is they have not looked at this as you actually need centralized management to make good public health policy. CDC actually can't be out front all the time making policy without consulting with other parts of the government. And so you saw kind of missteps early on with, whether it was, vaccines and saying, well, okay, they prevent infections, therefore, people who are unvaccinated don't need to do anything, to early, guidance about not wearing masks, where there wasn't enough coordination across the White House and other governments. So there's actually this balance of interplay between just the right amount of management from above, not interference, but management from above, and then the right amount of freedom for public health agencies. And CDC has really struggled in that regard. And I would say the other part of this related to that is, and this is right now, is that CDC just has not done as good a job as it should. And it knows this because literally CDC has written the book on public health risk communication to explain the rationale behind its decisions. I was deeply disappointed, for example, in a decision that CDC had the ability to make, and was upfront about this. And again, jumped ahead and did this without consulting with other federal government agencies to say that, if you get COVID, you only need to isolate for 5 days. And after that, as long as you wear a well-fitting mask, you can go out in public. They never explained in detail why they did not recommend the use of antigen tests or to help make that decision. And so many of us were left to surmise that it was due to supply, that because there's not enough supply, it can't be used, or surmise that, and then they said it's based on modeling data. And that was a completely unforced error. Like, CDC has historically not made policy changes by press release, which is what that was. What they've historically done is release a policy guidance document and then have an annex or detailed guidance of the scientific rationale for that. And that should have happened. So I've been really disappointed with CDC. At the beginning, it was really explainable by the direct, and I say not management, interference by the previous administration. And in this administration, I think it's been hampered by actually not enough careful management to ensure that policies are more carefully considered and explained before they're actually released.
So a follow-up question to that is, what changes are needed in how we train public health professionals to engage with the public?
Oh, yeah, this is a huge topic. There are a number of things. I actually wrote I can send you the link if you want to send it to people later on. I wrote an essay that was published in the Harvard Business Review in December about, kind of critical leadership skills that have been missing in public health professionals. I mean, there's a lot of communications and leadership skills of public health professionals, but in that article, and I wrote it with Dave Chokshi, who was the former health commissioner, as well as Ted Long, my colleague who ran the test and trace corps, and we were kind of a team of advisors to the mayor. We wrote about 5 unique leadership challenges that aren't normally addressed. And in that essay, one of the things we talked about was the ability to manage within government is just as important as your ability to speak and manage publicly. And what are the things you need to be able to manage within government? Well, first of all, you have to be able to distill complex scientific information rapidly and explain it to decision makers in a way they can understand. And that is not a skill that you necessarily get in public health. When you get in public health, there's the ability to do that kind of in a very academic way, like how can I review all the literature? But in emergencies, you need to be able to do that rapidly. And so there's a real skill that's required to be able to absorb that information and be able to explain it to people, to different audiences. And that includes within government, because executives in government, they don't, your mayor or your governor, they don't have public health training. So you need to be able to explain. That's one issue. A second is the ability to think much more flexibly in times of emergencies. And this was a real challenge that the city faced. It really faced this challenge. This scarcity mindset is what I refer to it as in public health, which is this notion that public health people have traditionally felt that, well, we're not going to get a lot of money. So if I only think I'm going to get $1, I'm only going to ask for $1. Well, maybe you need $100 or $500 to actually do the job right. You need to be able to ask and advocate for that. And a lot of public health people have not been able to think like that. And it was very striking to me because I spent a huge part of my career working in Africa and in Asia and in very poor settings. And that shift actually occurred during the HIV epidemic, where a lot of developing countries realized they need to ask for what they need, not just for what they think donors or other people will get them. So, escaping the scarcity mindset. Another critical skill that public health people need to be able to do is to really be able to transparently consider the entire range of how you get a policy implemented. So one of the unfortunate phrases that's come out of this epidemic has been this notion that you follow the science. Public policy never can just follow the science. It starts with the science, okay? It has to start with a scientific basis, but it then has to consider a whole range of things that have to do with real world implementation. What are the harms, and not just the medical harms, but what are the larger social harms? What are the, is it feasible? Is it acceptable? Is it legal? Is it ethical, and are there justice? And so public health people need to be able to learn to think and communicate about these issues in a way they can communicate them very effectively, both internally and externally, in a transparent way. And then it really gets to my criticism of CDC, right? That, for example, when they made this decision about isolation, they didn't explain this in a way that was very rational and clear and explain. And I think and there's a lot more I could talk about this, but the last point that I would make is that public health people also have to be able to communicate in a way where they are actually, honest about what they know, what they don't know, and how they're working on trying to fill things in. I think that one of the words I've used probably the most in the past year and a half is about humility and trying to explain to people. And I don't know how effective I was, but I used it all the time because I sincerely mean it. that we as scientists and experts have to be humble about what we know and don't know. And I do think that admitting that there are things that we don't know, while it has risks because it can be exploited by people who want to criticize you, ultimately builds the trust that you need. And when it comes down to it, public health people are only effective if we have the trust of the people that we're serving.
Well, I often thought that, during the height of the pandemic, Dr. Fauci was looked at as a hero. He had a bobblehead, became a folklore hero. And then in New York, Governor Cuomo, who would go on TV every day and just, he would, have a scientist there and all these things. But he became incredibly popular. People all over the country tuned in because they weren't hearing it from the Trump administration. And then, of course, they get knocked down for various reasons. So here's a question. I think this is a good question. Is there any
let me interrupt you just for one moment and touch on that. I mean, I think there's two things that I think are worth highlighting here. One is this was another example of a problem, though. Tony Fauci, who's a brilliant scientist and a real American hero, he is actually not the face of public health. He's the face of NIH. And for those of us who work in public health, we've always been a little bit irked by the fact that CDC was not put front and center, because NIH is a research organization and it can contribute tremendous information about the science of this, but it doesn't have to deal with the practical policy implications. And so I think that was a challenge early on. And number two is, I think for those of us working in public health, I don't think it's actually good for people in public health to have sort of this hero notion. Like, even though I view these people as pretty heroic in what they did, it would have been ideal if there was a array of different advisors that were getting public airtime who could speak in an honest and transparent way, because different people connect with different audiences. So I have no criticism at all of Tony Fauci's science or his ability to communicate, but I think that the whole system that was set up in some ways, it put CDC in a losing position, in terms of public communication and internal strategizing within the government. And number one, and then number two, I also think it set them up to failure, because it was easy. If there's a single person, then they can be a villain too, right? Not by me, but they can be vilified by the people. Well, there's multiple people. It's a little bit harder to do that.
Okay. So is there any country whose response to COVID can serve as a model for handling future pandemics in the United States?
Excellent question. And I think there's no real example out there of any country that did it perfectly, because everything, has balances of harms and benefits. I would say that early on, for example, I thought, South Korea, Singapore, and even Germany, if you pick European countries, did a great job of really, communicating effectively with the public, scaling up capacity for testing rapidly, making that data very widely available and communicating it very effectively throughout. What you've seen throughout this pandemic, though, is that this is such an incredible stress test on your government, on your society, and on your public health systems, that even if you were successful in some areas, you have failed in others. So, for example, in South Korea right now, there's still incredibly high infection rates, and I'm not quite sure what those are due to, but there have been, pretty good vaccination efforts, but there's been sort of challenges related to that. Singapore left out all of its huge migrant population, didn't do great by them. And Germany's having a lot of the problems that the US had about this, federalist system in response to vaccines and rising case rates. So a lot of countries did really well early on, but struggled at other points. And we see that in China, for example, which by the most well agreed upon metric, which is the number of excess deaths that occurred as a result of this infection, China comes out on top, relative to its population. But now you're seeing where the limitations are, because they're because of sort of nationalistic pride. They didn't allow higher quality vaccines in the country, and then also didn't push them on older people. And so as a result, they face challenges. So there have been lots of weaknesses around. Now, it's very easy to point to a place like, say, New Zealand and say, oh, they did it great, we should replicate them. But we have to be realistic. Look, quite honestly, if you are a geographically isolated place where the only way you can get into the country is by international port of entry, over air mostly, or boat, it is very easy to control your borders, first of all. And second of all, when you have a much more homogeneous, smaller population, it's easy. Scale really matters. Even if you have homogeneity, scale matters. And the US has both heterogeneity and scale. And that makes things very challenging, on top of all the other, really the biggest challenge that we've had as a country to this epidemic was, civil divisions, the lack of trust of individuals with government and the lack of trust with each other. And those are not going to be fixed by the public health system.
Okay. So we have a question about wastewater testing, and someone wants to know where we can see that. I wrote for the American Public Health Association about wastewater testing and didn't know a lot about it. And I did find out that New York City has a very big wastewater testing people. And I said to the guy, "What'd you do during the shutdown?" He said, "We never shut down. I was always in my office." So
Yeah.
why don't you first explain what wastewater testing is and why it's important? It's because now people are talking about it. Years
Yeah.
ago, nobody was talking about it, why it's important, and how, and also the question is, where can you see the data?
Yeah. Okay. So let's go through a couple of things. So I actually, when I got here in April of 2020, is actually one of the things I worked on very early on was working with what's called DEP, the City Department of Environmental Protection, to evaluate, the testing of wastewater or sewage for monitoring COVID infections. One of the biggest, and let's talk about what this is basically. Basically, what it comes down to is that obviously, humans excrete, through their feces, things that are in their body. Turns out one of the things you will excrete, when you have a COVID infection is detectable virus in your intestinal tract. So even though you don't get a stomach infection, the virus will still be shed in your stool. From everything we can tell right now, that virus generally is not infectious, although there's some debate about that, whether it's still potentially infectious, but broadly speaking, it's not. But as a result of it, all of their feces is going through, it goes down your pipes and it goes through centralized, treatment points throughout the city. So if you sample that wastewater and can test effectively for COVID, and I'll talk a moment about why that's really challenging, you can, in theory, get a sort of a measure of the amount of COVID that there is in a given community. If everybody, the ideal would be, let's say you're in a school or you're a prison or some other congregate setting and everybody's stool is going through the same place, you could sample it at the point where it comes out and test it and get an estimate about how much COVID there might be in that community. The advantage to that is, as we know, some people have COVID and they don't have symptoms. Some people have COVID and have symptoms and don't get tested. But this is agnostic to that, right? Because everybody's going to poop at some point, and it doesn't matter whether you've been tested or not, it's going to show up in your stool. So that's the good news, and that's why it's good. The limitations of this, and these have been limitations since very early on, is it's actually quite challenging to extract just the DNA, or in this case, the RNA of the virus, the molecular sequence of this virus only, when your stool is teeming with microorganisms, bacteria, viruses, maybe even parasites or other types of organisms in them. It's very difficult to extract that. It's a scientific challenge in terms of like the actual scientific processes of identifying it. And it's a computational challenge because you actually get all this DNA and you got to figure out where it matches to and things. So that was a huge problem early on, was trying to develop techniques that could be standardized across different places. The other problem that you have is, let's say 5 of us use the toilet, or let's say 50 of us use the toilet. How do you know it's not one person excreting a lot of virus as opposed to 10 people excreting just a little bit? So there's also mathematical and scientific challenges in trying to figure out, not can you even detect it at all, but what does it actually mean? Does it mean you have a lot or a little? So there's been a lot of extensive scientific work that's gone on over the past years to try to elucidate and answer these questions. And CDC is now publishing the data on its website and trying to put it in a more standardized way. But there is quite honestly a lot that still needs to be learned about it. And I think most of us are very wary of making public health decisions based on it. For reasons that I don't know, the city has not made this information publicly available on a city website. As far as I know, somebody can please correct me if I'm wrong. I stopped kind of working on this issue kind of in, early 2021. By that time, I was sort of fading out from my position in full time. And so I stopped asking about, why. Early on, we didn't put it out because we didn't know how to analyze it in a way that was interpretable to other people. But now I think it's only available on the CDC website. But people should push the city to release it and analyze it on the same data site it has currently.
It is only on the CDC website because I did.
Okay.
There's one last question I want. Well, before I get to that, I want to ask you. What are you doing? What are you doing at Weill Cornell? What is the Cornell Center for Pandemic Prevention and Response?
Okay, yeah, great. So I spent 20 years in government, all of that with CDC, but assigned to different places around the world, Africa, Beijing, Bangkok, and here in New York. And and I was interested in just taking some time out from government and had this great opportunity, both the Weill Cornell Medicine, which is the medical school, as well as the university campus in Ithaca, were interested in having me come and create a new center to basically help generate new knowledge and improve training and service related to pandemics. Obviously, this is an issue that now people are much more aware of, and it turns out there are a number of areas, as we've talked about on this, this conference right now, where there is knowledge gaps about how best we can predict the course of epidemics, how best we can prevent epidemics from happening in the first place, how we can protect healthcare workers while they're in them, how we can respond more effectively. So what I've been doing is working on creating this new center, and we're going to be setting up our website very soon, setting out some seed grants and things to try to bring together the best experts that we can from Cornell, and I'll talk about why Cornell is uniquely positioned from this, to try to develop research questions that are focused on very, very specific public health applications, like how can we protect people better? And then try to design studies that can then directly impact policy related to pandemics. Areas that I am particularly interested in include trying to get better ascertainment of threats and try to develop real-time kind of modeling and prediction, so guidance for local health departments about what the threat represents to them. That's one area. Another area I'm very interested in are aspects of how we can improve indoor air quality. We've learned throughout this pandemic that we should be working on this with the same vigor that we work on cleaning water. So that's another area. We're also trying to develop collaborations with New York State and other partners on training and service, locally. And I have some collaborations that I'm working on globally to work with WHO, a lot of colleagues that I did before. So this is going to be a center that's really going to try to bring together all the best the university has to offer. And one of the reasons I really emphasize the value of Cornell is we know that the vast majority of emerging infections, over 75% of them, come from animals and have some interaction with the environment. What Cornell uniquely has, unlike any other university in the country, is a world-class human health center, medical school, a world-class veterinary school that focuses on the emergence of infectious disease, and tremendous programs on agriculture and ecology. And we know that new diseases emerge at the interface of where humans and animals are often interacting for the first time, the edges of where jungles and forests are being cleared out. And so one of the real advantages and one of the exciting reasons that I wanted to work at Cornell was this opportunity to work on what we call One Health, which is this notion that you can't solve these problems only from the human health sector. You need to be collaborating with the animal and agriculture and other sectors. So, my center, one of the first things I worked on was trying to identify a co-director, even though, I'd love to be in charge of stuff myself. I really wanted there to be a partner in this. And so my partner is a guy named Alex Travis, who's a well-established public health professor, but in the College of Veterinary Medicine in Ithaca. So the two of us together are going to be working on various aspects of how we can advance all of these issues that we think are critically important to the future.
So your colleague, Dr. Salvatore, that's a question that she asked me to ask you.
Okay.
So for New York City folks who wore double masks everywhere and were boosted last November, I was shocked to find out by a PCR that the Omicron variant. I got my PCR too late to get the antivirals. I'm 65. So for about how long is immunity expected for being infected with Omicron? What are the steps are recommended and when? And she said her PCR was 12 days ago.
Yeah. So, let's talk a little bit about, let's step back for a moment and talk about what the vaccines can and can't do. So, early on, and by early on, I mean literally when the original studies were done, and first the Pfizer vaccine was authorized, and then Moderna was, I made sure that we were messaging publicly through the city that vaccines are focused on preventing severe illness and death. And that is because that has always been the purpose of vaccines. Even the polio vaccine that everybody uniformly, hails, was not what we call a sterilizing vaccine. It didn't stop people from potentially getting infected with polio. What it did was it stopped people from getting severe disease, particularly paralysis. And so that was what we always want to do. But what we saw very early on was this dramatic reduction in infections. And so many of us, because there's lots of aspects of the immune system they don't fully understand, got actually quite excited, and saying, actually, it looks like these vaccines, mRNA vaccines are almost magical. Like they're doing something we didn't think was possible, which is prevent any infection from occurring in your nose and throat, because that's what was happening. Now, what we have learned by following this out is that benefit does exist, but it only exists for a relatively short period of time. So somewhere in the order of 3, 4, 5, maybe up to 6 months, do you have really good protection against any infection whatsoever. And so that's what the challenge is that, people would like their vaccines, including me, would like the vaccines to block you from getting any type of infection at all. But it appears that that benefit from vaccinations is relatively short-lived. The good news is that the most important thing you can get protected against is severe illness, death, hospitalizations, and deaths. And it does appear that, again, 2 doses is pretty good, but 3 doses is incredibly good at providing, fairly complete protection, including against new strains like Omicron and these new subvariants that have emerged over time. Now, so that's why we can't always expect vaccines to provide us with all of that protection against any infection. But they could be used, and there's no harm that we know of in getting, repeated exposure to these vaccines every 4, 5, 6 months. Because honestly, people are exposed to virus without them even knowing it from time to time, and your immune system handles it without you even realizing it, right? So as far as we know, there doesn't appear to what we call immune exhaustion from repeated exposure, but we're going to learn that as we go on. So it may be possible that people at high risk need to get, reboosted periodically, but we don't know that yet. The next issue that was being raised is, what is the durability of immunity against Omicron? We don't know the complete answer to that. What we know from lab studies that have been done so far and some observational data from real world is that people who got infected during that first Omicron wave likely have some protection against these new subvariants. I think reinfections are not very common, but that doesn't mean they don't occur. So they still can occur, but you appear to have some protection. We just don't know how long that lasts. Many of us who work in this area worry that the immunity won't be very long lasting, because a lot of people who get Omicron, especially if they've been vaccinated, tend to get an illness that knocks you out. It makes you feel, bad, but it doesn't make you so sick that you need to be in the hospital. And as a result of, because it doesn't cause as much systemic illness, you may not get the longer lasting immunity, that you might get if you had a more severe illness. So paradoxically, having kind of more what's relatively minor infections, none of these are totally mild, but less severe infections might produce less lasting immunity. But this is all an area that's still being kind of worked out right now.
So what do you think about the second booster? Because the Biden administration said they recommend everyone 60 and over to get it, for 50 and over, maybe.
And this is again because this is in public health. You're dealing with this constant battle over, as information is emerging, you're trying to make decisions in real time. And so, the way I look at it is that, let's say you're somebody that's 60 and old. Let's just take that group for a moment right now. Just weighing benefits and harms. Okay, is there any harm to getting an additional dose of vaccine? There is no harm that I can think of. Yes, people will have an expected reaction of maybe getting a fever or getting aches and pains or getting chills for 24 or 36 hours. To me, that harm is like the harm that saying that I shouldn't go running because I'll be sore the next day, or I shouldn't lift the weights. That's just your immune system being exercised. That's the only harm that I know of. All these other harms that have been talked about that people have been concerned about with immune exhaustion or other things, there doesn't appear any evidence anywhere that this is likely to happen, and it doesn't happen with other infections as well too. So I don't think there's any harm, and there is possible benefit because the immune system, this virus does seem to take advantages of alterations in the immune system that appear to be age dependent. Like literally, the difference between a 60 and a 65-year-old is enormous, as is the difference between a 65-year-old and a 70-year-old and a 70-year-old. So there is certainly benefit to it. I'm not encouraging people to run to get their second booster, but I do think it's worth walking to go get one if you're in that age group and above. For people who are 50 and older, the data is unclear. We haven't seen studies on it. I don't think there's harm to it. I myself just turned 50, but I don't have any underlying health conditions that put me in higher risk. I'm not necessarily seeking to get it, but that's not because I don't feel that it might benefit me. I just don't feel an incentive to do it right now. And so I would generally give that advice to most people.
So Joe Bonner, my co-chair, said, have you talked about mixing Moderna and Pfizer vaccines? No, we have not. So why don't we talk about that? So
yeah.
I know people have had 3 doses and they're getting 3 Pfizer doses, they're getting Moderna or getting 3 months. And they said, it's much better. It's much better. And I say, how do you know? So
Yeah, there was one, I haven't seen the final published data on this. There was an NIH study that came out, I think, a few months ago from basic laboratory data showing the advantages of what we call heterologous. So basically mixing different types of vaccines. This is just and so this is basically based on guesswork, I think, right now. I think there's some lab data to support it, but there is an advantage, I think, to your immune system being stimulated in slightly different ways against the same thing. So, very early on, I can just tell you an anecdote. The mayor, when we were trying to figure out messaging very early on, once the J&J, Moderna, and Pfizer vaccines were approved, I told him, I want all three of them. Like, honestly, like, give me one, give me a month later, I'll take all three of them. He's like, you can't say that. Like, we were in the middle of, like trying to message, and there was scarcity of vaccines. And I was saying, I don't care. I want to get all three of them at some point. And I still kind of feel that way. I haven't gotten the J&J one yet. I mean, I got the first 2 doses of vaccine I got were Moderna, and then the booster I got, the 3rd dose, was a Pfizer. So I do think that probably mixing and matching, there's probably some benefit. I can definitely say there's no harm that I know of, and there's probably some benefit. One advantage to the Moderna vaccine over the Pfizer vaccine is because they actually have a stronger, like basically a larger dose of the mRNA in it. And so from every study that's ever been done, the Moderna vaccine does appear to produce a stronger short-term protection, as well as probably a more durable long-term protection. So if somebody has the option to get all three in front of them, I generally recommend the Moderna one.
but the booster doses are half the one, so
Yeah, exactly. Yeah. And so whether it really makes a difference or not, I don't know. But I think just getting well, actually, no, let me correct that. No, the 3rd dose of vaccine is the same one. It's in children that the dose is reduced. Yeah. The dose in adults, it remains the same. It's really just a 3-dose vaccine. In children, it's been reduced.
I think the 2nd booster is half, though. Moderna.
Oh, is it? I haven't checked, actually. I don't know.
Friend of mine got it. So sending a live at a sketch said, I don't understand this, mixing and matching. He said, I go to a doctor to give me an antibiotic and say, well, you take a week of Zithromax, then we're going to switch it to this, then we're going to this, or you can take them all at one time. He said, are they just making it up? So,
Yeah. And this is a real challenge. I mean, I think people are seeing the debates that happen in public health that normally happen over the course of 5 or 10 years, and they're seeing them over the course of 5 or 10 days. Right. And what they're saying is, you guys don't really know what you're talking about. And the answer is, that's not true. The answer is, we're dealing with imperfect information that's coming in continuously, where we constantly have to revise ourselves. And unlike elected officials or let's say a religious figure, we can't just default to saying that we're going to keep holding our beliefs no matter what new information poses. I mean, the whole power of science is to change your views as new information comes in. And unfortunately, that does come at the risk of some people then losing trust in you, which I wish they wouldn't. But the reality is that's one thing that does actually happen, and we have to accept that fact.
Well, I was at a Nobel Laureates Week in Germany, and the trust in science, the mistrust of science is a worldwide phenomenon. And one person said, but it's also selective. He said, people want to go on an airplane that's been inspected by an engineer. They don't want, they don't want a citizen who just says, I'll take a look. What the heck, they want to be in elevators that are inspected by elevator inspectors. So it is kind of selective.
It's very odd, and I think we need to. I'm not sure there's going to be. I mean, as much as I love social science, and I would love to see somebody analyze this question, I don't get it. I don't get why, whether it's Joe Rogan, for example, will go out and, if that guy breaks his leg, he's not coming to me for the best advice on how to splint his leg or whether to do an open reduction or to cast it. He's going to an orthopedic specialist. So why is he going to longevity experts or heart disease epidemiologists or other, basically charlatans out there who say they're doctors but don't actually have any expertise in this? And it's just completely baffling to me. You're exactly right. You wouldn't take your car to me to fix your fuel pump. I mean, unless you wanted to never have your car work again, right? And so, go to the people that know what they're talking about. And the reality is, it is very strange. And you'll see it. Look with the athletes, for example. Like, they're not going to go to anything other than the best surgeon to manage their physical injuries. But when it comes to infectious diseases, they're going to talk to their friend's cousin who knows somebody because he was a nurse one time or something. And yeah, it's very, very strange. But I don't know if there's a real answer out there to this.
I don't know either. Anyway, I want to thank you for spending time with us. It's been a pleasure. We'll be talking in the future about some other aspects of COVID and all kinds of things. And I really want to thank you. I saw you on Channel 1 last week, talking, and I just thought it'd be great to have him on the show. And I sent you an email and said, absolutely. So I really want to thank you for doing it, for lending us your expertise and wisdom, and thank you again. And everyone out there, stay safe, and I'll be sending out an email about our next, we're still waiting to hear about our next guest. So, okay, everyone take care. Dr. Varma, again, thank you. And thank you, audience, for those listening in, and also the really excellent questions. They were great. Okay, take care, everyone.
Great, thanks a lot, David.